I'm Dr. Yu. I'm the current PGY3 internal medicine resident from Kingsbrook Jewish Medical Center internal medicine residency program. Today I'll be talking about the kidney cancer, what you need to know about the kidney cancer. Today I'm going to talk about the kidney cancer and what you need to know about the kidney cancer. So we're going to start with what is a kidney. So kidneys are bean-shaped organs that are located on each side of the back, mid-back. So what do? So they filter the blood and remove the excess of water and waste in the formation of urine. And then the types of kidney cancer. So then mainly they categorize into the three groups. Renal cell carcinoma, it accounts for like 80 to 85% of all the renal cell cancer, and then they differentiate into three different types again. It is called clear cell renal cell cancer and non-clear cell, and then if they don't go into those categories, it is called unclassified renal cell carcinoma. And about 8% they are transitional cell carcinoma. And the rest of the tumors, it is a Wilms tumor, which is common in pediatric patient populations, and another one is the renal sarcoma. So out of 9 out of 10 kidney cancers, they are from the renal cell carcinoma. And I'm going to talk a little bit more about the epidemiology. So the incidence, it varies from region to region globally. And in the United States, there are approximately 74,000 new cases of renal cancer diagnosed every year, and about 15,000 deaths from the kidney cancer. And it is more common in males than in females, and the median age at diagnosis is around 64. It is very rare to have the renal cell cancer under the age of 40. The incidence is low in Asian Americans or Pacific Islanders compared to the other population like American Indians, Alaska Natives, Hispanics, Latinos, whites or African Americans. And these are the risk factors that's already established association with the renal cell cancer. The important thing is smoking, hypertension, obesity, and acquired cystic disease of kidney, and the rest. So I'm gonna explain to you a little bit more about the risk factors as well. So for smoking is related to all cancers. It has the cigarettes, they have a lot of carcinogens, and you name the cancer, one of the risks is smoking. So the increasing the number of the cigarettes that you smoke, the risk of having the renal cancer is higher, and then the advanced disease at the time of presentation is also increased. Hypertension. Hypertension is another factor that increases the risk of the renal cell cancer. It is independent. The risk of the renal cell cancer, it is independent of the type of the antihypertensive that you use. But the underlying link, it is still unknown. And obesity is another risk factor that increases the risk. So the higher the body mass index, the higher the risk of the renal cell cancer. And I'm going to talk a little bit more about the acquired cystic disease of the kidney. So it develops in like 35 to 50% of patients who are on chronic dialysis. The risk of developing acquired cystic disease is more common in men compared to women, and it is more common in African Americans compared to Caucasians. So why the acquired cystic disease of kidney develop the pathogenesis, it is not clearly understood yet. But the hypothesis is that in chronic kidney disease, there are nephrons lost, and then it leads to the compensation from the rest of the good nephrons, and it leads to the more hyperplasia and then formation of the cyst over time. But it is not fully understood why they develop the acquired cystic disease. But in patients who develop the acquired cystic disease, the risk of having the renal cell cancer, it is 30 times higher in dialysis patients when compared to the general population. And of course, there are occupational exposures like cadmium, asbestos, petroleum byproducts. It increases the risk of the renal cell cancer. And if you smoke on top of the occupational exposure, the risk becomes higher. And analgesics like acetaminophen, Tylenol, aspirin, most of the patients, they complain of pain. And they use a lot of over-the-counter analgesics, Tylenol, aspirin, because it is readily available. So there are studies done. They found that the increased frequency the risk is increased in patients with heavy analgesic use and who have developed the kidney disease from the analgesic use. So it happened in patients who have used analgesic for a long time, at least 8 to 10 years. And the tumor diagnosis is apparent after 15 to 25 years of chronic analgesic use. And there are genetic factors that also contribute to the renal cell cancer. So the risk of second renal cell cancer, it is increased in patients who have been treated for renal cancer before. And the risk of having another cancer, it is more pronounced in patients who were diagnosed with renal cell cancer at young age. And there are also the hereditary, which means the genetic contribution without a clear-cut genetic disease. In patients who have the first-degree relative means the parents or the siblings. They are diagnosed with tumor. Or the tumor diagnosis age of onset is under 40, or who present with the bilateral or multifocal disease. So they have the genetic contribution, but no clear-cut genetic disease for them. And then inherited polycystic disease. Inherited polycystic disease it means that they were born with a genetic factor. They have the multiple cysts in the kidney. It is different from the acquired, which develops later in life. And these are the factors that modify the risk. So it is not well established yet, but they found that diabetes is associated with a modest increase in risk of renal cell cancer. And of course, the polycystic kidney disease, this is the inherited one. And there are dietary factors. Dietary factors is those processed food, like hot dogs, all the processed food with the nitrates in it. They have higher risk of having the renal cell cancer. And those who are type 2 cancer survivors. So they have the increased risk of having the renal cell cancer. Alcohol consumption, on the other side, it is not related to increase the renal cell cancer. It is in fact kind of have the protective effect for the renal cell cancer. But it is not to encourage you to start drinking. It is just a fact. So, in kidney cancer, how do they present? Most patients, they don't have any symptoms. That's why cancer is asymptomatic. When it is symptomatic, then sometimes it is late. But if they do have symptoms, these are the most common symptoms that they can present with. They found blood in urine, sometimes they have the back pain, flank pain. On the physical examination, they can present with the mass or so in male patients, they can present with swelling around the left testicle. Most cancer patients, they present with weight loss, night sweats, or unexplained fever. But only a few % of patients, they have the symptoms. So how do we diagnose the renal cell cancer? So we can do either CT scan of the abdomen or the ultrasound. Another thing is we can do MRI, and rarely we do the angiography for the diagnosis. Do we do tissue biopsy for kidney cancer? No. In most cases, we just, after the imaging study said that there is the cancer, we just do the surgery. Kidney cancer is different from other types of cancer. Usually other cancer, we need the tissue biopsy before we start the treatment. But in kidney cancer surgery, we do the surgery, and then we send the surgery sample to the tissue biopsy for the final diagnosis. But we can do the diagnosis by the imaging studies. And then when do we do the tissue biopsy? When the tumor size is very small, or the patients are not the candidates for surgery, then we do the tissue biopsy. So after the presumptive diagnosis is made by the imaging studies like CAT scan, ultrasound, or MRI, then we evaluate the patient for the extent of the local disease and then whether they have the metastasis before the surgery. So as I said before, the role of the tissue biopsy, it is limited. We use to confirm in patients who are not surgery candidates prior to the medical therapy. So in all cancers, we do the staging. So staging tests, why do we do the staging? To measure the size of the tumor and to see whether the tumor has spread or not. These are the tests that we do for staging of the kidney cancer. We have to do the abdominal CT scan. Sometimes we do with including the pelvis. Sometimes we don't. Or the MRI. Chest X-ray is a must to see whether they have the metastasis to the lungs. And then we do the imaging test with the contrast whenever it is possible. And then the other tests are like brain MRI test, CT scan, bone scan, all those things we do for the diagnosis of the metastasis. Needle biopsy when the patients are not candidates for surgery, urethroskopy, urine cytology, and genetic testing. Those tests can also be done. And then cancer staging. It is to know the extent of the cancer in the body and then to plan for the treatment options which are best for the individual. So American Joint Committee on Cancer, they created a way that to determine this staging. So it is called TNM staging. For almost all cancers, we use this staging system. So T represent for the primary tumor itself, N represent for the lymph node, whether there is the lymph node involvement or no, and then M stands for metastasis. So for kidney cancer, this is the staging. For stage 1, the tumor confined only to the kidney, and the tumor size is less than 7 centimeters. Stage 2, still in the kidney, but it is more than 7 centimeters. And for stage 3, tumor has spread to the inside the veins. And stage 4 is the tumor has already gone to the other organs. through the blood. So for treatment is for every cancer, we go with a team approach. So the team would include the primary doctor, the urologist, the oncology specialized in urology, and then the team will also include the medical oncologist and the oncology nurses. And then if the plan includes the surgery, the team will include more people like surgeon, anesthesiologists, who do the reading for the imaging, like diagnostic radiologists. There will be nutritionists, pathologists, and surgery oncologists. But this is your body, you know better than anyone. So you have, once the treatment is to be started, you have to let everybody on the team know how you feel, what you need, and what is wrong with you, and what is working, what is not. Only you will know what is working. The rest of us, we are only focusing on the imaging, labs, and everything. Only you can feel that what is wrong with you. And then I'm going to talk about the treatment. So the definitive treatment for kidney cancer, it is the surgery. So in most patients, surgery is curative in patients who doesn't have any metastasis. So it is the preferred treatment for stage 1, 2, and 3 diseases. So the choice of the surgical procedure, it depends on the extent of the disease. So whether they will do the cryotherapy for very small tumors or radiofrequency ablation. And then it can also be done in patients who are not the candidates for surgery. And then if they are planned for the partial nephrectomy, which is the removal of part of the kidney, or total nephrectomy, which is removal of the whole kidney, one kidney which involves the tumor. So they can go with the conventional approach, or there is an option for laparoscopy and also robotic surgery. In patients who have the multiple renal cell cancers, so they have cancer in both sides of the kidney. So it is common in inherited genetic conditions. Still, surgery is the mainstay of the treatment. So in this case, like if both kidneys are involved, so when they do the surgery, they spare as much as renal kidney that they can save as possible. And then they have to continue monitoring, like is there any recurrence of the cancer or not. They need to continue to monitor. So advanced renal cell carcinoma. Advanced renal cell carcinoma means that patients have metastasis. The tumor has spread to other parts of the body like liver or brain or lungs. So the first line of treatment, so we send patients for immunotherapy. I'm going to talk later about what is the immunotherapy. After that, still, if they are candidates for surgery, so debulking of the tumor, like removal of the tumor as much as possible. Before we start the initiating therapy, is still recommended systemic therapy. So if it is not resectable, like we cannot remove the tumor, it involves the vein, or the patients are not candidates, they are not stable enough to go for the surgery, then we do the systemic therapy. We start the treatment as soon as possible. And then our second line treatment are patients who disease progress after the first line treatment. So they don't respond to the first line treatment. So we go to the second line treatment. It is the targeted therapy. And then treatment beyond second line, there is another alternative called anti-angiogenic agents. So what is the targeted therapy? So So targeted therapy is the antibodies. They make the antibodies outside and then they give the antibodies to the patients and then to attack the cancer cells. So there are two types, monoclonal antibodies and another type called kinase antibodies. So one type is it affects the surface of the cancer cells, they destroy the cells. And then another type is they destroy the inside of the cancer cells. And then the rest of the three types, they are from the targeted therapy. And this is the immunotherapy. Immunotherapy is the systemic treatment. So immunotherapy increases the activity of the immune system and it improves the body's ability to find and destroy the cancer cells. It can be given alone or it can be given together with other types of treatment. It is used to treat the stage 4 cancer or the relapse. So immunotherapy has two kinds, the cytokine therapy and the monoclonal antibody therapy. So cytokine therapy, it is only used in certain patients. Patients have to be healthy, otherwise having the kidney cancer, because they need to be able to handle the side effects of the cytokine therapy. Overall, they need to be in good health except having the kidney cancer. It is given by infusion. And then the monoclonal antibody therapy, it is also the antibody thing. It is like to attack the cancer cells, they build it outside of the body and then they give it to the patients. So this is the National Comprehensive Cancer Network guidelines for the kidney cancer treatment. So if there is the suspicious mass, if we are suspecting of the kidney cancer, so what do? We have to follow the guidelines. So if there is suspicious mass, we do the initial workup, which includes the patient encounter, history taking, physical examination, doing the labs, ordering the CAT scan or ultrasound or the MRI. And then we found out patient has renal cell cancer. Then we do the staging. Whether patient has stage 1, stage 2, stage 3, stage 4, the treatment is different. So in stage 1, they again separated into two groups. Stage 1, T1 and T1A and T1B. So tumors less than 4 centimeter, they call it a stage T1A. So they can do either partial nephrectomy, it is preferred type of surgery. It is the removal of part of the kidney, not the whole kidney. Or they can do the ablative techniques, or if the tumor size are very small, they can do the surveillance. No treatment is given, they just to keep monitoring the size of the tumor. Or the treatment option can also be removal of the whole kidney. It depends on the individual. After that surgery, we still monitor the patients for at least 5 years. I'm going to go through the surveillance in the future slides. In stage T1B, it is like tumor size between 4 centimeter and 7 centimeter. They do the surgery and then follow up for at least 5 years. Stage 2, the same, removal of the kidney, partial or radical. Radical means removal of the whole kidney. And then whether the patients participate in the clinical trials or go through the surveillance. Stage 3, also the surgery. And then for stage 3, we start the adjuvant therapy, either immunotherapy or targeted therapy or surveillance. And stage 4, for stage 4, whether they can go for the surgery or not. If they can go for the surgery, we do the tissue sampling. So stage 4 is different. We don't do the surgery first. We do the tissue sampling, and then we give the systemic therapy, or if they can go for the surgery, we do the debulking surgery. And then I'm not going to go through this. So after the treatment, we have to keep continuing monitoring the patients. So for stage 1, how do we follow up? We have to follow up patients every year. And then during the active surveillance, so surveillance we do 5 years. So during the active surveillance, we do the scan at least every 6 months for 1 year. Within 6 months, and then 1 year, and then yearly. We have to keep doing the imaging studies, labs, and everything, just to monitor like whether they have developed new cancer. For stage 2 and stage 3, we do more frequent follow-ups. Even the imaging scans we have to do every 3 to 6 months. For at least 3 years, and then we do every year. So for those patients who receive the adjuvant therapy, so they need to have the clinical follow-up with the oncologist every 3 to 6 months for at least 3 years, and then annually for up to 5 years. But this patient who receive the adjuvant therapy, they need to see the doctors every 6 to 16 weeks to get the for the imaging studies and then clinical status and everything. So long-term follow-up after 5 years, it depends on individual. It can be, you can continue to follow up with your primary doctor after 5 years, but you still need to see your primary doctor every year, have the labs done every year. Imaging tests, you can continue. It depends on what your primary doctor thinks. If they think that you need to continue to have the imaging surveillance, then you have to do it. So after surgery, how do we continue to follow up? So why do we do the follow-up? Because we want to know whether there is a new cancer developed. We want to get the early diagnosis of the cancer, or whether they have developed the metastasis or the second cancer, second renal cell cancer. Why do we do the follow-up frequently in the first 2-3 years? Because the risk of recurrence is the greatest in the first 2 to 3 years. So after 3 years, the risk of recurrence is less, so we do the less frequent imaging studies. So follow-up plan after the 5 years duration, it is individualized at the discretion of the treating physician. So this is the initial evaluation and treatment for the renal cell cancer. So that is the treatment and then the follow-up. So those patients who don't have the kidney cancer, who don't have the symptoms, do we do the screening? We have screening tests for other types of cancer, like breast cancer, we do the mammogram every year. For colon cancer, we recommend doing the colonoscopy or the stool testing. So for renal cancer, do we do the screening? The answer is no. It is not recommended to do the screening test in patients who do not have the symptoms. And everything has like catch point. So we still do the imaging studies, the screening tests for patients who are high risk of having the renal cell cancer. Who are the high risk individuals? They have the inherited conditions like multiple cysts in the kidney, or patients who are dialysis. So the risk of having the kidney cancer in dialysis patients is 30 times higher than the general population. So we recommend the patients who are on dialysis for at least 3 to 5 years to have the screening for renal cell cancer. Or if they have very strong family history of renal cell cancer, we recommend them having the screening test. Or if they have prior radiation therapy to the area around their kidney, then we recommend them to have the screening. So this is the survival rates of kidney cancer. So if this is from between 2008 and 2014. So the localized cancer means stage 1 and stage 2 cancer. So if we get the diagnosis at the localized stage, the survival rate after 5 years, it is 93%. Regional means it is stage 3, some types of stage 4 cancers. The 5-year survival rate is 69%. The distant stage means that patients already have the metastasis to the lungs, liver, bone. So they have poor prognosis. So their 5-year survival rate is 12%. But overall, the kidney cancer survival rate after 5 years, it is 75%. So the survival, as you can see in the graph, so stage 1 cancer, if we get the diagnosis early, the survival is higher compared to the late stage at the time of diagnosis. So mortality, so the 5-year survival rate of the patients with kidney cancer, the survival has increased, has doubled in the past 50 years, from 34% in 1954 to 62% in 1996, and now we have the 5-year survival rate for average all stages of cancer, 75%. But the incidence also increased, 3 times increased. The improved survival and case fatality rates. Why do we have the increased survival? Because we are diagnosing the cancer at early stages. When we get the diagnosis early, we can start the treatment early, and then it can lead to the increased survival. And then we have the curative surgical treatment. So these are the references that I used, and then this is the link for the patients. So for patients, you can go to that website, the NCCN.org, for the patients portal. Then you can see every recommendation they have made. They have updated they have do the updates every few years, and then you can see all the information for the patients, what you need to know, what you need to ask to your doctors when you get the treatment, what you need to initiate, and everything. It is in that guideline. Thank you very much. Do you have any questions? Yeah.
You said aspirin increases the potential incidence. Is it regular aspirin or baby aspirin?
It is the regular aspirin, and then you have to take the aspirin like every day for more than 8 to 10 years. So it is like prolonged chronic use, not the baby aspirin.
An individual who has diabetes in their family was diagnosed but is under control and complains about back pain all the time. You think that's one of the symptoms?
It is always good to have discussed with your primary doctor, and then you have to go through all the physical examination and lab testing. If they really think that you need to have the ultrasound, then they will do the screening. Yes.
Someone who's on dialysis, the kidneys are no longer functioning. Do you you recommend they keep them or just take them out because they're no use to them at this point, you know? Or what are the chances of developing that cancer?
So that is the reason why they recommend the screening in patients with dialysis, because they can have the risk of developing cysts in the kidney, and then those cysts can transform into renal cell cancer. That's why they recommend. But I don't see any recommendation about taking the kidneys out.
Thank you.
Can someone who's had parathyroids removed be a candidate for renal cancer?
This is so the parathyroid, they remove it for the high calcium or some other reasons.
Yes.
But there is no association with them developing the renal cancer.
Thank you.
Yes.
You did mention that there are 74,000 cases of cancer, renal cancer in the US every year.
Yes.
15,000 people die. I'm assuming that you mean that they die within the 5-year period or after the 5-year period?
It's in the 5-year period.
Okay. Now my question is, what is so significant about that 5-year period versus a 10-year period? How many people with cancer who had the cancer die within 5 to 10 years? Has that been determined?
So from 5 to 10, after 5 years, they have survived the first 5 years. So I don't see the the survival rate that they follow after 5 years. But since they have survived the first 5 years, it is the higher chance that they will survive the rest of it.
Okay.